So I am going to talk to you, as Hannah said, about the cafe journey. Um, and really, it's a bit of a heuristic for us to be able to have conversations about um, delivering culturally informed care for people with psychosis and but obviously it has wider implications. So that's the kind of conversation I'd really like to engage us in. But just to kind of put a context to it, I know many of you will already know this, but I'm going to just put a little bit of background in terms of why psychosis. And so this, can you see the slideshow, or are you seeing?
No, we are seeing your notes.
Yeah, I didn't really want that. Okay. Is that better?
That is better. Thank you.
Okay, great. Okay. All right. So this is the kind of backdrop that many of you with this, many of you would be familiar. So um, people from sub-Saharan African and Caribbean backgrounds. And I'm using that phrase deliberately because so many of the people who are in our services are actually British born and raised. Even their grandparents were British born and raised. But we continue to refer to them, particularly with Caribbean people, as being Caribbean, and they have those origins, but they're not. And I think that is potentially really important in terms of what we're going to talk about around cultural adaptation. So these are some of the stats that you'll be really familiar with. A lot of them came out of KCL and Craig Morgan's work. And I'm using these figures because these are the ones that informed the work that we did around starting the cafe journey. So I'm very mindful that these were taken from ESOP, and there have been few studies since. And actually, there's some kind of dispute. There are some people like James Nasru, who question these rates. There are others where the rates are even higher. So putting that aside, these are the data that we use to really make the case for why we needed to explore developing culturally informed psychological therapies for people from these ethnic backgrounds. So there you can see that well, generally for kind of for psychosis, generally the relative the risk ratio for Black Caribbean people is coming up towards 7 times that greater than for white British, and about 4 times greater for Black Africans. And when it comes to psychosis, schizophrenia, narrowly defined, it's near 9 times for Caribbean and about 6 times for Black African. And alongside that elevated risk of being diagnosed with schizophrenia in particular in the UK, and the note should be, this is not the case if you're actually in the Caribbean. The rates are very similar to the global prevalence. We have these negative care pathways. So traditionally, people have thought about people as non-engagers and being quite often delayed access to care. But actually, some of the work that was done in the ESOP studies found that far from not engaging, people on average were making 6 attempts to engage with services before they actually came in, which meant obviously by the time they did, people have much more chronic symptoms, for example, much more problematic relationships at home, much greater risk of being compulsorily admitted versus more benign routes through the GP. It's about 4 times greater risk of being compulsorily admitted. And then once in care, much more coercive care, so higher rates of seclusion, medication, and poor access to kind of more evidence-based psychological care in particular. And alongside that, generally speaking, worse clinical outcomes, so including an inpatient stay of roughly 2.5 times greater than for white British people. And obviously that's all deeply problematic, not just for the individual who's experiencing strange feelings that they might not know how to interpret, they might not have any clue what these things are. They may be very fearful, very anxious. May think that the people around them are involved in what they're experiencing. Maybe the perpetrators, so maybe quite isolated and withdrawn. And you have families who often don't understand what's happening with somebody who may be in their mid to late teens, early 20s, at a time when it's not uncommon in lots of families that there is conflict because of adolescence, and some of the behaviors, particularly the more negative symptoms, might just be chalked up to adolescent behavior. But nevertheless, this is what's happening within families, and we have seen evidence of families that have been kind of holding this for years. So not just months. When we talk about delayed access, we're talking for sometimes that people, by the time they actually get into services, it's been years since they start their first episode. And many of you will know that the representation of people from minoritized backgrounds in first episode psychosis services is actually quite poor. But so what you have is families who are dealing with trying to manage things that they probably don't understand, and the conflict, which we know is not good for anybody's mental health, but we know it is particularly bad in terms of people experiencing carer burden, and also the conflict within families can also make symptoms worse, and certainly don't create the pattern to support recovery. So this is the backdrop to why we thought family intervention, family therapy might be a good thing, and that really came out of some conversations that I'm going to tell you about in a moment. But just to go back a little bit, so we know that there's really strong evidence, which is why we've put this up here about for family intervention for CBT, for CBT for psychosis. And I just put this in italics, a bit about nice recommendations. So it's for service users in regular contact with their families. And, you know, your people at KCL, so right there in London, with one of the most diverse cities on the planet, and just thinking about what that might mean, not just in terms of ethnicity, but who are the people who are most likely to access your services, and the extent to which some of them will have regular contact with their family. And if that's what the stipulation, what might that mean in terms of people having access to this form of evidence-based care? We do know that there's limited research about acceptability, accessibility, perceptions of utility or engagement, or even the impact for people from minoritized and racialized groups. And we absolutely know that implementation and uptake of family intervention in the NHS is really poor, despite the really strong evidence and ongoing, I'm sure many of you be aware, is that there's NHS England now rolling out training to make family intervention much more embedded within services. And we also know that for reasons which we'll probably come back to, the uptake, at least in part, the uptake is especially low in African and Caribbean and other minoritized groups. And that's partly because people are not offered. It's not just that people say, no, we don't want it. It's because often they're not offered. Way back when, NICE recommended that we needed more. So there was an urgent need in the Schizophrenia Guidance to say that there was an urgent need to develop more culturally informed care. So here, this is what they said. What they said was that services should work with communities to jointly, and I'm not quite sure how you do that, but anyway, that's the nice recommendation, to jointly ensure that a more culturally appropriate psychological and psychosocial treatments are developed that are consistent with the guidelines, delivered by competent practitioners, and is provided to people from diverse ethnic and cultural backgrounds. Okay, and that all sounds great, doesn't it? And then you think, well, yeah, but how do you actually do this? How do we make sure that services, that the interventions that we're going to do are culturally appropriate and culturally informed? And this is where I think, I'm going to just put these 3 points up. I think it's really important that we start from moving away from maybe what we've done traditionally and use deficits models of evaluating individuals and the communities to which they belong, and thinking much more about the strengths and the assets within those communities, and making sure that that kind of thinking is integral to both service design and delivery, and really importantly for us in the context of this conversation, research design, the methods that we use, and importantly also how we share that information. And this is just a quote which I'm sure many of you will be familiar with. This is from NIHR from involved. It's quite a while ago, but it still stands the test of time about making sure that good, genuine co-production is about working together with the people who are the end users, and that's the patients, the researchers, practitioners, the public. And at the heart of it is about a shift in dynamics and relationships and greater sharing of power and responsibility. And that this is not something that we do by kind of inviting people to a PPIE group. Nothing wrong with that, but it needs to be more than that. So it's from a start of the project all the way through to the very end, including knowledge generation. And I've added a bit about sharing as well. So this is how we did it in terms of the cafe journey. So we started by having conversations with people, as I mentioned, service users, their families, community members, practitioners, other agencies, including the police, social care, a whole range of different people and policymakers, and saying, we know this has been an ongoing problem. We've had 60 odd years of research showing this ethnic disparity, this inequality in access, experience, and outcomes for people from minoritized communities, and especially so for people from Black, African, and Caribbean backgrounds, including those who have mixed and multiple heritage. And we've had those conversations over a series of events. And at the heart of it was to kind of take a solutions-focused approach. So yes, we had to explore the history and where we were, but also to look at, okay, so what are we actually going to do about it? And we use that information to think about, well, what are the priorities in terms of research? What can research do to make this, to shift the dial? And out of those conversations came the proposals for 2 research studies. One, which was CAFE, which I'm going to tell you a little bit about now in a moment. So initially, there was a feasibility study, which was funded by HSNDR, Health Services and Delivery Research. It's now Health Services and Delivery and Care Research now. And then the other one was research with patient benefit. And the first one was looking at culturally adapting family therapy. And the second one was really looking at how we can provide better information for families. So this is a recurrent theme where families were talking about not understanding, didn't understand symptoms, didn't understand how the system worked, didn't understand what their rights were, for example, when somebody was being sectioned. And we use that information to create an online tool which people then use to look at the extent to which it improved their knowledge. So this is the kind of co-production journey. It started with us to kind of do what we always would do as academics, looking at what's already out there, what's in the literature, and we use obviously not just peer-reviewed publications, we looked at grey literature as well. And with some of the things that people were saying, it was how important it was when we talked about cultural adaptation, that we weren't just thinking about language. That was really important. So we had to go beyond translation to actually looking at how people conceptualized experiences that they were having. We used focus groups and individual interviews to look at the core components. So what we did was we took a standard CBT-based model of family therapy, and we explored the different components and the way it was structured, and asked people what needed to change in order to make it more culturally informed. And some of the things that people talked about being really important were addressing the elephant in the room of racism, and then making sure that within the therapy we were going to challenge and address stereotypes and misconceptions about Caribbean cultures. And you see I've deliberately put it in the plural because there is no such thing as Caribbean culture. It's very different across the different islands, let alone when you then start to look at sub-Saharan Africa. All right, and then we took all of that information to an experts consensus conference. So we had experts by experience and by profession, and their job was to really refine the content, the outcome, and the way we deliver the intervention. And so 2 of the things that came out of the therapy that were really important is that people said, actually, the components look okay. what's in here, yep, there's some things that we absolutely need to add, and I'll talk about those in a moment. But actually, it's not so much the therapy that needs to change, it's the therapists. The therapists need to know how to work with diversity and difference in a way that is really meaningful. And so we commissioned Just Psychology to work with our therapists. So all of our therapists receive work around, and I put it in bunny quotes, calling it cultural competency, because frankly, within a few hours, at best, people can become more aware. Depending on where you are, there are people at different stages of the journey. You might learn a few more things, but the extent to which one can become culturally competent, especially when there's no framework for assessing that, I think is a bit of a moot point. Anyway, so what Just Psychology did was to work with the therapists around cultural awareness, looking at how cultures might play out within family work. So not just looking at the families, but thinking about the dynamics with the therapists. Really importantly, talking about people's lived experience of racism and discrimination, and how that might be expressed as psychological distress, and what that might mean in terms of the power and the dynamics, the relationships and trust building in therapy. And the information that we gathered from the literature review and elsewhere, one of the things that people said is that we needed to develop a therapy manual, which was a manual with a difference. So we needed to put in there something about the historical nature of how people came to be in the UK in the numbers that we are in now. We know there's a long history of people from Africa and the Caribbean in the UK, but going back to Roman times, but we're talking about the numbers that we have now. And so really looking at that, particularly for Caribbean people, talking about things like the transatlantic slave trade and what that meant. We had to do some work about how CAFE was developed so that the people who were going to use the manual had an understanding of some of the things that I just talked about in terms of cultural awareness and the process. Oh, not sure why that's done that. And then we also talked about the ethos of delivery. So going back to what we said when paper was saying, when people in the development stage are saying, actually, it's not so much the therapy, it's the therapists. So we needed to look at how we work together to deliver therapy. So in CAFE, what is traditionally called psychoeducation is called shared learning. And we've moved away from talking about cultural competence to talking about cultural humility. Right? And then we looked at the different components, and what we discovered was that there was very little in terms of resources for family therapy. You sought cards and so on that you kind of bread and butter as therapists. There was very little that actually bore images that would reflect a lived experience of the people that needed our therapy. So we also developed those. And then importantly for the therapists, explaining the difference between delivering therapy in practice and in research. And I just thought it was important to put this slide in because one of the things that people talked about and raised about why we needed to do that work around cultural awareness was about the workforce. Because we asked about, I guess, essentially what used to be called ethnic matching and the extent to which service users felt it would be beneficial, preferable to have somebody who looked like them or somebody with a similar ethnic background to deliver the therapy. And what people said, they were very pragmatic and said, if we were going to wait to have enough Black therapists to deliver this intervention, we'd have a very long wait. And in any case, we're operating within an NHS, and it should be that people working within the NHS should be able to work with diversity and difference, and not just in terms of ethnicity, but thinking about those other protected characteristics in the sexual orientation and so on. So as you'll see there, of the nearly 27,000 practitioners, UK psychology practitioners, only still 500 are Black or self-identified as Black. Okay, so a long way to go. So a little bit about CAFE. So with all that work, what we ended up with was, kind of a fairly standard approach to family therapy, starting off with engagement and assessment. And And the elements that we really highlighted were things like different models of and expressions of mental health and belief. So those different models, including things like spiritual explanations, and then thinking about family dynamics whilst avoiding stereotypes. I've already mentioned the shared learning. So really importantly, understanding for the service users' perspective of the families, they really wanted to understand how services worked. They really wanted to understand their rights and so on. They really wanted to understand the relationship between medication and illicit drugs, lots of stuff that they didn't really understand. And also wanted to make sure that in therapy, the therapists were equipped to kind of challenge some of the misconceptions without kind of undermining people's beliefs. We included, this is a departure, so we ended up with this hybrid model. So it's definitely a departure from standard CBT therapy, where we've got much more focus on communication and thinking about the importance of the way language is used, not just the words, but the way that they're used and how they might have very different meaning for people from minoritized and racialized groups. Obviously, stress management and coping, and really looking, it's one of those areas where we really looked at community assets and what are the assets that people had that were in communities that could be used to really support stress, not just stress management and coping, but also enabling people to remain well, to maintain those gains through therapy. So here we are. So at the end of that, we ended up with these 10 sessions of therapy. As I say, it's a hybrid model, so a big mixture of CBT and behavioral family therapy, delivered by therapy dyads, trained in the way that we've explained in cultural awareness and family work with these resources. Going back to the point that I made about NICE recommendation for family intervention for people in regular contact with their families, and knowing that people with serious mental illnesses over a period of time will tend to lose contact with their families, their social networks shrink. We know that for everybody, irrespective of ethnicity. But we knew that the way people from our study population arrived in the UK, and importantly also that the way they often came into services through conflict, might mean that they were at increased risk of having no one to take part in therapy with. So we piloted the concept of family support members as therapy partners, and much later on we also developed a digital offer. So I'm just going to do a couple more, then maybe we can have some questions about this bit. So in terms of the feasibility study, so we did a small feasibility study because we didn't know whether any of this stuff would work. And we did that in Manchester. We did all the refining, and then we did a small randomized control trial just to see whether people would accept being randomized, whether they would, we could recruit people to test the intervention, whether they would come to the sessions, whether they would continue to come, whether they would see them, the therapy as acceptable. Importantly, one of the important findings was that over half of the service users who took part needed one of these family support members. And really positive for us was that people, everybody was, there was unanimity that people thought it was something that was worthwhile and worth rolling out nationally. Some of the benefits: service users talked about improved understanding of their experiences, better functioning and things like going back to work and education. Really importantly, better communication both with families and with services. For the family members, they talked about understanding, again, better understanding of the condition, diagnostic process as well, not just the experiences, better engagement with services, feeling more empowered to be able to engage with the services as well as with service users. So being better advocates for service users. And then for the health professionals, just greater understanding and awareness of some of the challenges that people from Caribbean, and I should say that the feasibility study, we focused just on people of Caribbean origin to make it doable. But for the next phase of the study, we then expanded that to people of sub-Saharan African and Caribbean backgrounds. and really pleasing. We had great feedback from the therapists that they were using some of the skills that they had acquired in the materials in everyday practice. There's a short video that's accessible. I'm happy for the slides to be shared afterwards, so you can just click on the link. And then we did for Granada ITN, they did a small feature where they went back and talked to a service user who had received CAFE participated in the feasibility pilot and talked about the impact it made on her life. And it won't do a spoiler, but it was good. So it would be good if you want to watch that. And just to finish this bit of the presentation, we talk about co-production, and I just really wanted to capture this. And obviously, this is not all of the stages, but just to give it a bit of a plan on a page of what that might look like, what it looked like for us. So starting at the top left with community engagement, and then going all the way through to making sure that people were involved as co-applicants, as people who co-created the intervention and the therapeutic resources, members of research management groups, so research and trial steering committees. So really all the way through the study, including at the far end when we are doing dissemination. So people have co-presented at conferences. We've had co-authored publications, so that it's truly sharing that power and power dynamic between us. So I don't know whether before we move on to talking about RCT, I don't know, Hannah, whether this is a good place to stop to see if anybody had any questions. I'm happy to stop sharing if that helps.
Yeah, very happy to take a couple of questions now, if there are any also clarification questions before we move on. So very happy for people to put questions in the chat or raising their virtual hand, which you find in the reactions button on the bottom. Maybe I just had a very quick question around cultural humility, cultural safety, the more maybe American concept, and also how cultural humility also invites clinicians to think about their own cultural positionality, so that it's not just the patient who has culture, but they themselves have a cultural background too and are implicated in these power dynamics, and how that
and also actually for the therapists that they're multicultural. So even if they might describe their ethnicity, their culture as white British, they're also professionals, and there's a professional culture where there's different language and customs and norms and the way in which people operate. And so really understanding that when you're talking about working cross-culture, it's not just in terms of linked to ethnicity and race. It's also that people don't understand, literally, as people were saying to us, they don't understand how the system works, because the language that we use in clinical practice is so exclusionary, and some of the things that we see as being norm are not norm for anybody else, but we've kind of been socialized into that through our training. So I think it's really important that kind of self-reflection. And I should maybe also say that supervision is really integral, it's built into the model. And we have a Black woman therapist, is a systemic therapist, is a member of the board of the Association of Family Therapists, and she is one of the people who provides supervision along with Professor Catherine Berry, a clinical psychologist. So these two working together to provide supervision, which means that things that will come up, as they inevitably will, about racism, how to deal with that in therapy, how to deal with stuff coming up for yourself, can be dealt with rather than not ignored, but that there is a safe space in which to actually explore those issues. And that's a great question, stroke observation. And I do think some of this we don't know, right? But when what we do know is that when people are offered, they jump at the chance. So like you're saying, with the people who you've worked with, who have become practitioners. And certainly the nearest we've gotten so far in terms of CAFE is with the people who've become family support members. So what we said to kind of community, we said, look, we're going to have people who might want to take part in CAFE, but they don't have access to their families for a whole host of reasons. We know that there may be people, for example, who are care leavers, people who are, because they came fleeing conflict, their family, they don't even know if their families are alive, right? So there are a whole range of different reasons why people might not have access to their families, but might actually still really benefit from family therapy to deal with some of the issues that come up for them. And so we invited people to kind of come alongside and support people to take part in therapy. And on the little film, you'll see there's somebody there who was she was an undergraduate psychology student at the time. And then you also have, we had a range of different people. Not all of them were Black. We had Asian people, white people, we had a range of different tribes. Because again, I mentioned that whilst a lot of the research, when it's reported, it talks about African Caribbean, a lot of the people who are actually accessing our service are Black British, the majority, and many of them are mixed and multiple heritage. So it was really important that we had people who could reflect that diversity. And what we found, as I said, in the feasibility study, we had over half the people who did one of these FSMs. And what we found is when because SLAM was one of our recruiting sites, it was 80% of the people who wanted to take part. Interestingly, sometimes they started with a family support member because they perceived they didn't want to involve maybe often mum, and adding additional burden and stress and distress. So they said, no, I'll take part with this family support member. But once they'd started, then they said, actually, I think mum would really benefit from this and I would benefit from taking part. So what then happened, which is what we found in the feasibility study, people talked about the FSM role being a bit of a bridge to help people reconnect back into their communities and with their families. Okay. All right. So I mentioned that we did that was all this kind of a background to creating CAFE and testing it in a pilot study. And then we got some additional funding to do a randomized control trial. So this is much bigger across London, Great Northwest, Manchester, Midlands, the South. And the focus of the RCT, the randomized control trial, is to evaluate the cost and clinical effectiveness of CAFE compared with usual care. Really importantly, we embedded what's called process evaluation, implementation science, to look at implementation barriers and whether there were actually any facilitators, across the different sites, were there any things that actually enabled family intervention to be better taken up. And then we also look at things like accessibility, fidelity to the therapy manual, so the extent to which the therapist actually stuck to the manual, the way that it was designed, and then people's perception of the acceptability of the therapy. So progress, challenges, and lessons learned. Oh my goodness. So the first thing was that we were due to start the trial at the beginning of 2020. We were due to start on the 1st of April 2020. So I'm sure you all remember what happened then. So before that, what we'd done was that we'd done some refining work where we'd taken CAFE and we'd worked with people from sub-Saharan Africa, African origin, to refine the therapy itself and add some new therapy resources. So we were all set up, ready to go in April, and then we had to pause. In the end, we were delayed by 24 months getting started. And then when we got started, what we found was the impact of the pandemic on services, which I know that those of you who are in services, are well aware of. It was just really difficult to get going. It was difficult to access the service users because we couldn't get care coordinators. In one of our teams in Manchester, where there should be 18 care coordinators, there were 3. In one of our participating sites where we were looking to recruit therapists to deliver the therapy, there was not one single Band 7 clinical psychologist in the entire organization. So we really struggled. And because once we realized some of these issues, we made the decision that we would not actually try to open up other sites. So we should have had 7 sites, but for the most of the trial, we ran with just 3. and I'm happy to talk about this, if people would want, but we were then monitored, like most people would have been, by NIHR. And then in November of last year, they took the decision that they were actually going to withdraw funding from the study. So not close the study, but withdraw funding. So that meant we had to close to recruitment whilst looking for alternative sources of funding. But we continue to deliver therapy to the people who were randomized to receive the intervention and to collect the outcomes. So yeah, that's kind of where we're at now. So just thinking about some of the implications for research. Malik has always kind of started to touch on this and about how we do research with underrepresented groups. So we say we want to do that, and we know that NIHR and Wellcome Trust, all the funders are now talking about making sure we do more inclusive research. But what does that actually look like in terms of our study design and the extent to which some of our outcome measures are actually fit for purpose? So you look at any one of your standard outcome measure, whether it's PANS, PSP, and nearly all of these, and begin to look at them through a diversity lens, and you'll begin very quickly to see that a lot of them have not been tested for their psychometric properties in diverse populations and so on, but we continue to use them as though they are aproblematic. So I think there's some further work that needs to be done there. We took the decision that we would recruit therapists who are currently practitioners to deliver the intervention, rather than research therapists, which is the classic thing when doing RCTs, that you would recruit a dedicated trial therapist, and we really wanted this to be embedded. That didn't work so well for us because we found that therapists were being recalled to frontline duties. Some of the hidden costs of working with minoritized groups, which have traditionally not been involved in both in therapy and in research, which meant there's a lot of work around trust building, going to find people, like Malik is suggesting, going into communities, a kind of assertive engagement. And really, we don't have at the moment a mechanism for properly costing that into funding when we're doing funding applications. And then thinking about what the success criteria might be and how they might look differently for research such as this. And again, how we report things, and where we report. So I think making stuff really accessible in terms of our dissemination, finding different ways of reporting, which are absolutely, we need to use our peer-reviewed journals, and we need to go to conferences, academic conferences, and importantly, take the people with us who are part of the co-production team. But we also need to think about different ways in which we can use this information to transform services. And we have to be very honest and say not all of our practitioners are reading peer-reviewed publications, but also into communities to do stuff around education, reducing stigma, and so forth. In terms of policy, those of us who have been around for a while will remember delivering race equality. So that was in 2005 that the then Department of Health launched this massive piece of work, and the idea was, the aim was that within 5 years they would have delivered race equality in mental health, and nearly 20 years on, we're still sitting here having this conversation. So it's really important to think about how we learn the lessons, because we've now got patient and carer race equality framework, PCREF, that many of you will know about, that's being rolled out nationally. And how are we linking evidence-based interventions to evidence PCREF? How are we actually making sure that we provide evidence for cultural adaptation and cultural competence in a way that is meaningful, that would either say, yeah, this maybe makes a difference, or not? And if not, why not? Looking at those mechanisms. So it's a plea really for different kinds of policy-focused research. And then thinking more about the kind of practice end. So we are in a multicultural, multi-ethnic society in Great Britain. That's where we are. It's different depending on where you are, obviously. Places like Manchester, London, Birmingham, Bristol, have higher ethnic populations in some of the other communities. But nevertheless, maybe especially for those places where there are very few people that look like me, or from minoritized backgrounds, how equipped are the therapists to work with people who are different in those communities? Or when those therapists move into different parts of the workforce, how equipped are they? So really important to think about the all this language that's in practice about individualized, holistic, person-centered, needs-led. We use the jargon, but to what extent are we actually doing that? And I think at the heart of that in our therapy models is this concept for us of this shared learning, because it's so important that the therapists acknowledge that they have stuff to learn from families or individuals, as well as the other way around. Thinking again about therapy partners and the implications for that, not just to say for our study population, but for people like people coming out the care system, where we know that there's high rates of psychosis, but a lot of people who don't have families. Thinking about training and supervision, and how we make sure that it's costed into grants properly, but also in services where we know we are really struggling for supervision. And one of the ways of doing that, so we developed Cafe Digital, so we digitized all the intervention, and we found that being really helpful, because we can then work with supervisors from anywhere, essentially, to supervise our therapists. And then thinking about the workforce, so I showed you that slide earlier on about the NHS plans to radically overhaul the psychological therapies workforce by 2025. They really want to see some greater diversity, and the extent to which they're going to do that is really questionable, unless they're going to embrace different ways of working and recruiting different kinds of people to join the workforce. So when we struggle to recruit people within the NHS, we then went out through the Black and Asian Therapy Network. We engaged with people through the Association of Family Therapy to look at to bring in people to work with us who were not necessarily working within the NHS. And what we found were tremendous barriers in terms of governance, in terms of having to pay people through NHSP and various other things that made it very difficult. I mentioned Cafe Digital, so obviously more and more of us are working digitally. It does seem to be the way, the future. So the digital strategy that the government has, and so, but if you look at the practical outworking of that, so 20% of NHS organizations, only 20% would describe, and this is them self-describing as being digitally mature. Okay. Only 86% have any kind of form of patient record in place, any kind. And then we're not talking about necessarily the whole thing. And when it comes to social care providers, only less than half have any kind of form of digital record. So we also need to think about this, how equipped are our services to work digitally, and then how equipped are the people that we're working with to work digitally. So we know about the digital divide. Do people actually have tablets or smartphones? Do they have data that they can use? And if not, should that be part of the offer? It is for us. Where people elect to use Cafe Digital to receive therapy, we loan them tablets preloaded with data if they need that. Okay, so just to finish off, just to say, we've been talking about new ways of working for the longest time. I think it was about 2002 with the NHS plan. Is a long time. But I think if we are going to do that, we really do need to embrace these different ways of working. And for me, at the heart of that is this genuine co-production, which is transformational and not just transactional. Thinking about, genuine power sharing, recognizing that it's just a two-way process, making sure that all of the end users, and I do mean not just the PPIE, but really thinking about the practitioners. If the people who are actually going to be working with service users and their families are not involved in that co-creation process, then you're kind of losing credibility before you even start. Thinking about who's missing, who are the people, like we've had to think about family support members, who are the people who would not be able to access this therapy unless we fixed some of the process and system issues. And so really in the end, we need to be looking at this from multi-level system-wide approaches. So, you've got your FSMs in place, or what does that mean for your therapists? And if you're going to use digital, what does that mean for people who are not or digitally naive and the training? So there are lots and lots of moving parts that we need to address. And at the bottom line is it costs. And very often it's as I mentioned, there's not a mechanism at the moment for costing some of these things in a meaningful way into when you're developing grants. And too often in services, when services are being delivered, people expect that anything that's kind of EDI, equality, diversity and inclusion, that kind of work needs to be done for free. It doesn't really require any expertise. So those are some of the preconceptions and the challenges that we have to deal with. And really looking forward to entering into a conversation with you now, but please do stay in touch.
Thank you very much.
Back to you, Hannah.
Thank you very much, Dawn. This was just wonderful, such a rich presentation, so informative, so much to learn from. So thank you very much.